Welcome to EPG Pathashala. My name is Dugirala Vasanta. I am on the teaching faculty of the Department of Linguistics at Usmania University, Hyderabad. Today's lecture deals with course 10, it's Psycho-Neurolinguistics, module 22, the neurolinguistics part of it, and the title is Aphasias. The main objective of this lecture is to describe major causes and classifications of aphasia, and also to point out that language breakdown associated with stroke aphasias is very different in different languages. It's language specific. The nature of breakdown is language specific. So, to emphasize this point, I will share a little bit of data from Hindi aphasics. Aphasia has been defined as an acquired language disorder following brain injury, causing reduction in language content, language form and language use. Okay. It can also affect some of the cognitive processes like memory and attention, which definitely underlie language. The diagnosis of aphasia is based on neuroimaging techniques which correlate the site of lesion with diminished performance in language. Language tests, they administer a series of language tests. The performance is correlated with the location of the lesion in the brain, which is determined using neuroimaging techniques which I have dealt with in another module. So, what causes aphasia? As I said that in this module, I will only be focusing on stroke aphasias. So, stroke aphasia results when there is stoppage or diminished blood supply to areas which are supposedly involved in language production and comprehension. Alright. In the according to classical model, most language areas are located in the left hemisphere. So, suppose the left hemisphere language areas do not receive sufficient blood supply, or there is a hemorrhage, or there is embolism. I will explain these concepts in a minute. So, middle cerebral artery supplies most of the important language areas in the left hemisphere. So, if middle cerebral artery is affected, then you get stroke aphasia. So, a majority of the people who are diagnosed to have stroke aphasia have some problem related to middle cerebral artery. Alright. So, let us look at various causes of stroke aphasias in more detail. Look at the figure shown on the screen, which is called causes of aphasia. You see the leftmost figure is about thrombosis or thrombotic stroke. Cerebral thrombosis results when the blood vessel is narrowed, becomes narrow because there is a clot. A blood clot goes and lodges itself in a blood vessel, and because of the narrowing, sufficient blood does not go into it, and it can cause stroke aphasia. The narrowing of the blood vessel can also happen due to plaque deposits. Alright. They can also narrow the blood vessel. Other than thrombosis, the second major cause is embolism. It's referred to as embolic stroke, the middle figure. An embolus is a blood clot or other kind of debris which is circulating in the blood, which travels. It can form in the leg, but it can be carried into the brain through the blood circulation, and then it can get lodged in the middle cerebral artery, impeding the flow of the blood to the language serving areas of the brain, and that can cause stroke aphasia. The third major cause for stroke aphasias is hemorrhage. Okay, thrombosis, embolism and hemorrhage. Hemorrhage, as the picture shows, the rightmost picture shows, is a burst blood vessel. If for various reasons internal hemorrhage takes place, a burst blood vessel leaks the blood out. So, sufficient blood does not reach the region which is subserving a specific language function, and then you have stroke. So, with this kind of idea, I mean this noticing that these are the major causes of stroke aphasias, the initial understanding about aphasias is, the classification of aphasias is lesion based. In other words, the classical model which held that most of the important language areas are located in the left hemisphere. So, let us look at the picture on the screen which is showing the important language areas in the left hemisphere. So, you have the primary auditory cortex and the Wernicke's area in the temporal lobe. Look at the figure and the arrows are pointing out to primary auditory cortex and Wernicke's area in the superior temporal lobe, and you have Broca's area in the third frontal gyrus, the pink colored area on the in the pointing out as Broca's area. Then you have Wernicke's area is connected to the Broca's area through a band of fibers called arcuate fasciculus. Then you have angular gyrus which is involved in reading and writing. You have primary visual cortex. So, much of the information you see from the environment, you see that goes into the visual cortex, travels via parietal lobe, angular gyrus into Wernicke's area. Wernicke's area passes it on to, after interpreting the meaning, it passes it on to Broca's area through the arcuate fasciculus. Broca's area, it gives instructions to the corresponding muscles involved in speech production. So, Broca's area sends instruction to the motor cortex, to the area which corresponds to lip and jaw and palate and all this musculature, speech musculature which is involved in speech production, and we open our mouth and start speaking. And so, this is the classical model which has influenced classification of aphasias into Broca's aphasia, Wernicke's aphasia, and if the arcuate fasciculus is impaired, it is called conduction aphasia. So, when you classify aphasias like that, it is called lesion based classification. The second type of classification is impairment based classification. So, you can say non-fluent aphasia, which is expressive aphasia, which is same as Broca's aphasia. When Broca's area is damaged, because Broca's area is supposedly responsible for speech production, the patient has problems speaking fluently, alright. The patient will be non-fluent. So, Broca's aphasia is also referred to as non-fluent aphasia. The other terms for this is motor aphasia, expressive aphasia, and there are also two other aphasias clubbed under non-fluent aphasias, transcortical motor aphasia and global aphasia. Okay. So, all these different types of aphasias, the common thing is all of them have disfluent speech. The speech is not at all fluent. As opposed to these non-fluent aphasias, you have fluent aphasias. They are Wernicke's aphasia, transcortical sensory aphasia, conduction aphasia. Here, the patients who are diagnosed with Wernicke's or conduction or transcortical sensory aphasia, these patients speak fluently, but it makes no sense. Their problem is with comprehending other people's speech. Their own speech will be fluent. Okay. So, basically this classical model has guided all this, but more recently the aphasiologists have come up with flow charts to guide classification. See the picture on the screen. On the brain, the left hemisphere, the blue side is all the comprehension side and the red colored side is all the production side, very roughly. And so, you have aphasia, and if you ask a question, is the aphasia, can it be treated as fluent aphasia? If no, you come to the left side branch. If your answer is yes, you go to the right side branch. Okay. So, if it is non-fluent aphasia, then is the comprehension affected? Next question is comprehension affected or not? Alright. In non-fluent aphasias, comprehension is not affected. So, you see another no, N standing for no. Then does the patient have problem in repeating? No. In Broca's aphasias, non-fluent aphasia, there is no problem in repetition. So again another no. Alright. So you look carefully at this flow chart which has guided classification of aphasias into fluent and non-fluent and beyond fluent and non-fluent in relation to comprehension, repetition, like that. So I will not go into every branch, but I urge you to study the flow chart carefully to understand how this flow chart has guided the classification of aphasias. Now, the lesion, what we mean by lesion in 3 different aphasias, the next picture on the screen will explain to you. See, Broca's aphasia, look at the lesion site. It is corresponding to Broca's area. Okay, third frontal convolution. There is a big red mark there saying that this is the area damaged in Broca's area and the problem is production. Alright. Wernicke's aphasia is the superior temporal lobe, the red mark on the brain showing on the superior temporal lobe. When that area is damaged, you have Wernicke's aphasia and the main problem is comprehension. Okay, and they use a lot of new words, neologisms and things like that. We will go into details of patient's speech later on. But here I am talking about Broca's aphasia, lesion is in the third frontal convolution. Wernicke's aphasia, lesion is in the superior temporal lobe. And if the problem is with repetition and conduction aphasia, the lesion is in the fiber tracts which connects Wernicke's area to Broca's area. That is the you can see the lesion involving the arcuate fasciculus, and here repetition is affected. Okay, error filled speech, but comprehension is not affected in conduction aphasia. Okay, so this is about the damage. What is the damage in these 3 major types of aphasia? Of course, the figure on the screen next tells you about the various different aphasia types. You have, let me just read it out: Broca's, Wernicke's, conduction, which I have already explained to you, transcortical sensory, transcortical motor, global, ephemia, pure word deafness. Okay, so one of the earliest attempts to model aphasias was is shown here. It's called Lichtheim model. Geschwind and Lichtheim together they offered this model of motor aphasia affects production and the Wernicke's aphasia affects comprehension. So when the comprehension, they have shown an ear. For the production, they are pointing out lips in the diagram there. All right. But let's look more closely at what happens when you are diagnosed with Broca's aphasia. The speech of Broca's aphasia has a telegraphic quality because it affects small words, the grammatical morphemes, not the content words. That's why it's called telegraphic speech. As you know that when we send a telegram, we don't write the full sentence with a, and, the. Those are the words we omit. We put the content words. So the Broca's aphasic speaks as if it's only the content words are preserved. But please remember, this definition of Broca's aphasia, telegraphic speech, applies to English language. Alright. Very soon I will say that we cannot generalize this description to languages which are very different from English. For right now, you just remember that Broca's aphasia results in non-fluent speech where content words are preserved, but small grammatical morphemes like a, and, the are lost. Alright. In Broca's aphasia, comprehension is relatively intact. One is not saying 100% intact, but relatively intact. Therefore, the patients not only understand your speech if you are speaking to them, but they also know that they are not speaking well. So, they get upset. So, Broca's aphasics get more upset about their own condition. They show frustration and sometimes they refuse to speak. And of course, left hemisphere is involved. So, they get paralysis on the right side. right hemiparesis. It's either total paralysis or weakness on the opposite side. Left hemisphere is involved, so right side hemiparesis or hemiplegia happens because of the crossover of the fibers. Remember, we talked in the earlier module, 80% of the fibers cross over at the level of medulla. Okay. Now, persons with Broca's aphasia also have difficulty reading. They cannot easily retrieve appropriate words to use in conversation. Alright. Okay. Now, let's move to Wernicke's aphasia. In Wernicke's aphasia, the main problem is with comprehension, not production, right? Their speech is fluent. They tend to have what was called at one point logorrhea. In other words, speak in long sentences and lots of speech, so that are frequently unnecessary. You ask them something, they go on speaking, which is not related to the question you asked. All right. They even make up things and just keep on talking. They have a great deal of difficulty understanding other people's speech. There is reduction in reading, so Wernicke's aphasia also may be connected to dyslexia and in some cases even dysgraphia. You will learn about this in the other modules about dyslexia and dysgraphia. So let's now compare Broca's aphasia with Wernicke's aphasia by focusing on the salient points. Alright, Broca's aphasia is non-fluent, Wernicke's aphasia is fluent. Okay, Broca's aphasia is characterized by good comprehension, Wernicke's aphasia impaired comprehension. Broca's aphasia is also referred to as expressive aphasia because the problem with expression. Wernicke's aphasia is referred to as receptive aphasia because the problem is with understanding. Broca's aphasia is also referred to as motor aphasia, whereas Wernicke's aphasia is referred to as sensory aphasia. Broca's aphasia results in what is known as agrammatism, meaning impairment to grammar. Wernicke's aphasia results in paragrammatism with new words. They are not words in our language, they are called neologisms or they create new words. Alright. So, these are some major characteristic features which distinguish Broca's from Wernicke's aphasia. What about conduction aphasia? Because the lesion is located in the fibers which connect Wernicke's area to Broca's area. Remember that arcuate fasciculus? The lesion is located in the arcuate fasciculus. So, these patients' main problem is they cannot repeat anything, whatever you ask them to say after me, and you say a word, they can't repeat. You say a sentence, they can't repeat. Phrase, they can't repeat. Whatever you ask them to repeat, they fail to repeat. Alright. But their own speech is fluent. There may be some self-corrections. They're able to understand spoken language, but they do have some difficulty retrieving appropriate words in conversation. Reading and writing is variable, depending upon the lesion, it varies. There is a condition called anomia. Usually it comes with posterior lesions, that is lesions in the temporal lobe, not in the frontal lobe. Anomia, patients diagnosed with anomia experience considerable difficulty in naming day-to-day objects, everyday objects. You show them what is this, pointing to a chair, they cannot name. You show them a pen, you show them a pencil, you show them a spoon, everyday objects, no object they can come up with the name, but they know what it is meant for because they engage in what is known as circumlocutions. If you show a pen, they might even imitate saying that it is used for writing or whatever, but they cannot use the word pen. So, they will point to their head if you show a comb, but they cannot say comb. So, they know what the object, what the word is and what it refers to, but they don't get the word. Okay, so these are called circumloc, and then because they can't get it, they go around the bush. That's what is called circumlocution. They go around describing what it is meant to be used. So, in anomia, comprehension is preserved somewhat. Even repetition, they don't have major problem with repetition, reading and writing. they tend to use lots of pauses because they're not able to get the word. They use lots of pauses, but still their speech is relatively fluent because it's only a problem with naming objects. All right. Now, whatever different types of aphasias I have described so far in this lecture, I would like to say they are mainly based on English language. That's why they are Anglo-centric. All right. In the e-text, you will find samples of aphasias experienced by English-speaking patients. I don't want to repeat that here. You go back to the text, look at Broca's aphasics English sample, how it is, why it is called telegraphic speech, you will understand if you look at the sample. Similarly, I have given English sample of Wernicke's aphasic, of conduction aphasic. Many samples I have given there. Okay, but I would like to come back to our context, the Indian context, marked by multilingualism. It's not just bilingualism and multilingualism. All of us are biscriptal, multiscriptal. We write many languages, we speak many languages. So, what happens to aphasia in the context of India involving patients who know and use more than two languages? That is what I would like to engage with little bit. So, if you see on the screen next, I have given you a sample of paraphasias in Hindi speaking aphasics, which a neurologist was kind enough to share with me. The phonemic paraphasias in Hindi, for instance, I will read out only one example from the samples that I have given. You spend some time looking at it later on. So, the patient will say Kartak for Kartik, Kartik Masam, month of Kartik. When you ask them to say Kartik, the person said Kartak. So it's a phonemic paraphasia. At the level of phonemes, the mistake is at that level. What about semantic paraphasia will be something like this. When asked to say something like chaku, the patient said sabji. So, it is a semantic level. You cut vegetable with a chaku, he is asked to say chaku and the patient is saying sabji ko, sabji se, something like that. This particular patient is saying sabji se for chaku. Alright. Formal verbal paraphasias, the patient I believe said Sirlamba for Sri Lanka. Alright. I don't know, we'll need to think about what exactly happened to the patient. Neologism is Tarona for Ladka. Now, there is absolutely no phonemic level or semantic level relationship. It's a new word. What is Tarona? Nobody knows. So I don't know. That it's a neologism, new word created by the patient. There are other examples. I suggest you look at them carefully later on. But what is the explanation for phonemic paraphasia? I am giving another example shared by the same neurologist, Puranik from Indore has given me some of this data from his patients. Jugnu for firefly was pronounced as Gunju. Gunju. There is a reversal of phonemes. Semantic paraphasia, the patient observed sabji se for chaku. I have already read that out earlier. Here the intended word and the error belong to the same semantic field. Vegetables and knives with which you cut vegetables. At some level, there is some relationship, associative relationship between vegetables and knife, and therefore there is some confusion and one was substituted for the other. Formal verbal paraphasias like this Sarlamba for Sri Lanka, neologisms like Parki for Kursi, we have no explanation as to why they come about. Although researchers have made use of linguistic constructs like sonority, the perceived loudness, whether neologisms can be explained in relation to whether they follow sonority principles or not. Again, there is some of the reading material I have suggested in the e-text will give you this information. That is, there are articles which deal with sonority explanations for the kind of neologisms observed in aphasic patients. I will not go into details right now. But again, Pauranik published a study in 1996-97 in Usmania Papers in Linguistics, which I have edited and I have quoted it in the e-text. In this study, Pauranik shared data based on 40 different aphasic patients who came to his clinic. Broca's aphasics, he noticed, exhibited more phonemic paraphasias. Wernicke's aphasics exhibited more of anomias, all right, and more semantic paraphasias. Okay, so there is a need to examine the errors, such errors. He also said that there is a need to examine further, deeper into what is behind this kind of errors. Can sonority explain these errors? Do phonotactic rules of Hindi explain these errors? Recall your other courses in linguistics. Phonotactic rules are language specific. Which consonant can follow which other consonant. So, it is at that level more research has to happen in the Indian context. You take data from Hindi or Telugu or Kannada and you apply these linguistic constructs like sonority and phonotactic rules and see if we can explain these errors using those constructs. Let us now look at how agrammatism manifests in relation to English. See, an English patient was asked to describe a picture in which one girl is giving flowers to a woman. The patient, all that the patient could say is the young, the girl, the little girl is the flower, the girl is flower, the woman, the girl going to flowers, the girl giving, teacher, giving, teacher. This is how the patient is speaking. This is what we mean by agrammatism. Look, any of the sentences, there is no grammar. Okay, this is an example of how agrammatism manifests in English. What about agrammatism in Hindi? Let's look at the sample on the screen next. I'm not a Hindi speaker and I may not be able to read very clearly, so I will only read one sentence. Wo laak wood kat raha hai. To say, and he is cutting the wood. Here, notice laak wood. Wood is English. Laak obviously is Hindi. So this patient is suddenly both the words came to the mind. Laak wood kat rah. It's not even raha, rah hai. Okay, so that's how it manifested. I have given more sentences and I don't want to repeat. You please read and try to reflect on the nature of agrammatism in Hindi. But let me comment because I've taken these comments from Bhatnagar, who also is another neurolinguist. He shared his data with me. In fact, the data that I'm asking you to read is from Bhatnagar, Subhash Bhatnagar. He noticed that there are auxiliary deletions, but the principal verb that needed no agreement marking was provided correctly. If a verb did not need to agree with other components in the sentence, the verb was produced correctly. The difficulty in verb phrases was confined mostly to inability to use appropriate verbal inflections. The patient reportedly used erroneous conjugation and infinitival constructions without inflections. So again, as I said, you need to examine the data very closely to understand these points which mark agrammatism in Hindi. There is one more data. Prasannanshu 2008 reported some more data based on Hindi agrammatism. The examiner said, say he is bathing in Hindi, wo naha raha hai. The patient said, wo na rahega. So it means he will not stay, right? It's totally, completely different. The patient used future tense marker that was improperly affixed on the aspect marker. There was deletion of auxiliary and malformed verb. Conversion to past tense could not be accomplished by the patient. See the way Hindi is breaking down in agrammatism. okay, which is specific to Hindi language. The what I show on the screen next is example of parallaxias in Hindi, English, bilingual, anomic aphasia. Okay. Once again, these mistakes that occurred in this patient, please remember, is an educated patient, but because of the stroke, she or he, I don't remember, made lots of mistakes. You examine the mistakes carefully. I think I have some information. So, 42-year-old female stroke patient, master's level education, and the mistakes they made is SOLT for salt, SUTKES for suitcase, like that. You look at the mistakes the patient made, you know how it should be spelled, and you see how it is breaking down in aphasia. To summarize this lecture, I have given you a definition of aphasia. I discussed major causes of aphasia, especially with a focus on thrombosis, embolism, and hemorrhage. Then I talked about classification systems, and then I presented some data from English as well as Hindi samples to demonstrate how anomia and agrammatism manifest in these patients in English as well as in Hindi. Very briefly I described, but for more details, I request you to go back and consult the e-text and read the readings suggested in the e-text. Thank you.